All right, today's me. Actually, you're stuck with me today. I won't be back until at least January or February because we are full until that time. But this is a topic I've been just dying to do on the secret life of buprenorphine as a mental health drug. I even drew in one psychiatrist today, I've noticed already. Well, and some psych nurses. So today will be a fun talk on the secret life of buprenorphine as a psychiatric med.
We have some great upcoming talks on the schedule. We have Cole Perringer talking about inpatient methadone titrations. We have Haley Hillstrom and Troy Green from HIDA giving updates. And then Rick Moldenauer is going to be giving some updates on Minnesota methadone programming and maybe some changes that we're going to be seeing coming up. And also at the bottom of this screen, other echoes that are available are listed. If you want to continue to collect some free CME, check those out.
All right, and remember there's free CME. Please make sure that when Katie sends you something, you fill that out or you get nothing. So make sure that you send that back. And again, don't be afraid to throw that camera on. We'd love to see faces, especially when we're speaking. So I understand some people are shy, but think about it, consider it.
Remember, we're always here for technical assistance. Our contact information is listed at the bottom of the slide. So if you need help with any cases or protocols and policies, pretty much anything surrounding addiction, don't hesitate to reach out. We always say we might not be able to help with personal problems or, things of that nature, but give us a call or a text if you need anything.
All right. Again, there's some extra stuff on the Center for Opioid Resources, the core website. So feel free to reach out to that and find some of the things. Don't reinvent the wheel. There's lots of different resources on there that you might be able to use. All right. I don't know if you want to switch, if this is the actual slide deck, Katie, or if you got to put up the slide deck.
No, this is it.
All right. So today, so this talk, actually, I stumbled across some things probably about a year ago about, and actually more about suicidality with buprenorphine. But there's been a fair amount of talk surrounding buprenorphine, especially with its effect on the kappa receptor. And so today we're going to talk a little bit about some of the potential roles of the opioid receptors in these mood disorders and also in suicidality, which is really pretty interesting. Although, disclaimer, there's not a ton of research on this. There's a number of review papers, and actually I got the review papers and all the papers that they reviewed, and still it's not a huge stack. We're going to try and be more aware of the past and the recent studies. And the studies actually started almost, I suppose, 30, 40 years ago when buprenorphine originally came out. So it's been a while. And we'll talk a little bit about some of the studies that are going to need to be done, not only on buprenorphine, but some of these other kappa antagonists. And we'll kind of explain what's being looked at, but pretty interesting. Next slide. All right, so first we're going to do just a quick buprenorphine review, and I'm not going to review all the stuff we already know, just some funky stuff that I ran across as I was digging through these review papers and some of the papers that they reviewed. I went to a liberal arts college, so, it's always got to be well-rounded, and so we're going to also talk a little bit about some of the historical stuff, which is really pretty interesting as to where buprenorphine came from. Next slide. Katie, you must have fixed this because I had them in a bad order before. So the history of buprenorphine, and these are just some random facts. I think it's really interesting and I've given a poppy seed talk before, which is still my favorite talk in the world. But we never really knew, I don't think people talk often about where buprenorphine came from, but in fact, it is a semi-synthetic drug that's actually derived from thebaine. Now, as you may recall, thebaine is one of the things including there's morphine, codeine, and thebaine in the poppy seed and the latex of the poppy seed. And they take that thebaine and actually in 1966 synthesized buprenorphine out of that. And if you recall, even a talk I did a couple of years ago, much of this work was done at the narcotic farms, the place where you got sent from New York City and all around the country. If you had a problem with alcohol or opioids, and back then it was heroin, you would be sent to a narcotic farm, and that was actually in Tennessee. And so that's where much of this work was done on buprenorphine. Remember that buprenorphine is lipophilic. I think that's something that, especially with some of the things we're talking about, with the effect on depression and suicide and suicidality, this gets into the brain, and so that's important to understand. When Suboxone, or excuse me, buprenorphine originally came out, it was actually a Schedule 5 drug, and until 2002. You can go to the next slide, Katie. In 2002, of course, is when we started to prescribe it, and actually the first person who prescribed buprenorphine in Minnesota was Dr. Greg Amer, a friend of ours who's spoken on this echo before. But they switched it to a Schedule 3 drug. And important to just understand that the reason they did that was because it certainly causes moderate dependence, right? If people stop it, they do get some withdrawal. And it's in that same group with some of the stimulants and the depressants and others. Some of the things that have a little bit of codeine in it, like the cough syrups, are also in that Schedule 3 thing. Next slide. So again, if you look at buprenorphine, and we're talking about 4 opioid receptors, although I'm not going to talk much about the NOR receptor, the nociceptive receptor. We're going to be talking mostly about mu, kappa, and delta. But just understand that there's some activity with buprenorphine with really all 4 of those. And interestingly, if you look at all of the opioids, all of them to a degree have some interplay with each of these receptors, although we'll talk about how that can be really different. Now, buprenorphine actually, very interestingly, is one of the most common opioids prescribed by veterinarians. I have a veterinarian friend, had no idea they were using this. And in fact, a lot of diverted buprenorphine comes from likely veterinarian offices that get burglarized because they keep large stocks of this apparently in their clinic. And they use it a lot for chronic pain in animals, which I was unaware of. Just to give you an idea, even when we look back 7 years ago, Medicaid spent $1 billion on bupe. And I can tell you that in 2017, there were maybe 100 prescribers of buprenorphine in Minnesota, 30 of whom were actually prescribing. Now there's upwards of like 800. So imagine how much money we're spending in our state on bupe. Next slide. So a little bit of pharmacokinetics and pharmacodynamics. And it's important to understand that when buprenorphine enters the system, there's 2 ways that it gets broken down. And one is through the P450 system, which I know very little about and could care less about. But also it goes through the CYP3A4 system, which is one you kind of got to know a little bit about because there's so many different drugs that use that particular avenue. And it can affect the levels of buprenorphine and norbuprenorphine and some of the other metabolites. The CYP3A4 is actually the way that it goes to turn to norbuprenorphine, which of course is the largest of the metabolites. And it's also the one that if we do a confirmatory, we can actually see buprenorphine and norbuprenorphine levels, right? Now, often when we think about this, and I've gotten a lot of calls over the years about, well, how can I tell if somebody just didn't crush up a pill and put it in their urine? The ratio of that bupe to norbupe can really be important in giving you an idea of how recently they used it. But one of the things that makes that difficult is the metabolism from person to person can vary greatly. And so that ratio can really change at times. So that and the fact that, again, some medications people may take may actually increase their bupe levels as opposed to their norbupe. So it can be medication related as well. Next slide. Now, interestingly, it's really the buprenorphine that crosses the blood-brain barrier that probably has the biggest effect on some of the things that we're going to be talking about. When we look at norbupe, although in other animals, it seems to go across the blood-brain barrier. That's so hard to say. Especially like in sheep and other animals like that, it'll actually cross that barrier, but in humans, it does not appear to be. I never really considered much about the excretion, but of course, if some of this is liver excretion, a lot of the buprenorphine actually ends up in the feces, probably more than 2/3. So we're picking it up in the urine, but understand that more of it ends up in the stool than really anywhere else. And again, I already talked a little bit about how that metabolism rate can vary really from person to person. And so, what you're going to see as far as ratios can be vastly different. Next slide. So why does this 3A4 metabolism matter? Well, again, I talked a little bit about the drugs. Now, we certainly have patients in our clinic who are HIV positive, and often they're on medications. I have two, I believe. And one of the things you have to remember is that some of these HIV meds will actually increase the bup levels. They will block the metabolism from buprenorphine to norbuprenorphine. And so we'll typically have higher buprenorphine levels than we would normally see in an average person. Interestingly, it doesn't cause huge adverse effects for the most part. But if you look at cannabis actually increases our bup levels more. And in fact, in people who use very regularly, it actually can double their bup level, which to me is pretty shocking. I got to be honest, I didn't know that before I was kind of digging through all this stuff. We've always known that some of the antipsychotics may increase some of the bup levels, and it's very specific ones. But if people are on an antipsychotic, it's always something to think about. Next slide. So let's talk a little bit about the receptors, and I can't impress upon you enough how there is nothing really black and white about these receptors, and so as we go through this, for one drug, how it affects the receptors can be vastly different for the next drug. So, again, in the 70s, we learned that those opioids produce their effects by binding to these receptors, and interestingly, they found that out before they even figured out what was attaching to them. And it wasn't until later that it became obvious that there had to be something floating around that was attaching to these for some reason. And of course, the brain neurons were actually synthesizing their own kind of opioid-like peptides. And so a lot of the research was going into what really attached to what. Now, the receptors that we're going to talk about are really the mu, the kappa, and the delta. And these receptors were really found to have, very different selectivity for both the things floating around in your blood that are endogenous and to some of the drugs that we prescribe can be very different. Next slide. So here's when we look at these receptors, and gosh, I hate going down this deep into the brain, but there's these three receptors, and again, the mu, the delta, and the kappa. And if we bring on an agonist or a drug that's going to positively affect them, obviously with the mu receptor, the common thing is the euphoria. It's a stress coping thing. It calms people, right? And they've known that for hundreds and hundreds of years. Ever since the poppy seed was around, everybody knew that was something could relieve stress. And to this day, our mu receptor agonists, something that calms people down without a doubt. It's a great medicine for anxiety. It's just not sustainable. It's not something you could do forever without generally having a problem. Now, delta receptor, they believe is what really helps us develop that tolerance to these medications and also physical dependence. And so, that some of the drugs that hit that can, like with morphine or with heroin or any of those things, also will have delta activity, which they act as an agonist, and they will actually cause the tolerance. They will cause the physical dependence. And then lastly, the kappa, which we see this in all these patients who've been on opioids for a long period of time. And when we see these patients that have been on opioids for 20 years, they are not happy people. They have a lot of dysphoria. They are stressed. They're very negative people. They're crabby. I mean, to just put it very bluntly, they're some of the crabbiest people I've seen until they get switched over to something like buprenorphine. Now, obviously, if we have an antagonist, it will have the opposite effect on these. And that's where buprenorphine comes in, because buprenorphine is an antagonist to both the delta and the kappa receptors. So often I'll tell my patients that they generally won't develop a tolerance as much to the buprenorphine as they would a morphine or something else. And often I talk to them about how the difference we may see in their mood, depending on how the medication works for them. I do think that from person to person, again, there's some significant difference, right? Some people really, I think, get more of that effect than other people. Next slide. So to make it a little more complicated, traditional opioids generally have some level, remember, with all three of these receptors. The level that they activate a particular receptor can be very different for one drug to the next. And interestingly, they can land on the same receptor, but have a different effect. And so, and it can be a stronger effect. It can be a more downstream effect. It really is something that hasn't been worked out well, but we know that different things are going to cause a different response. So I think it's just something to understand that even if they hit the same receptor, what you're going to get on the end might be vastly different. Next slide. So the other problem is that all of these drugs have metabolites. And so as you can imagine, all the metabolites that buprenorphine has, they can be a bit of a wild card as to what they're going to do at these particular receptors. And if you look at buprenorphine being, a antagonist at the kappa and the delta, what are we going to do when all these metabolites of that come along? Do they do the same thing? And some of that has not been worked out. So we don't know really with even regular, agonist opioids like morphine or heroin or fentanyl, really what their metabolites do in comparison. And again, how strongly they attach can make a difference to the effect that we're going to see. How long the drug hangs around can really make a difference. And so really the bottom line is there's just a lot of moving parts. I mean, there are just so many things going on here that really, when I read through all of this, it's like, for me, I have to try and think about it a little more simply, and that's what I put on paper here. So, or on a PowerPoint. All right, next slide. So how does this all apply to this presentation about buprenorphine as a mental health drug? Well, it's first off important to understand that all the opioids are not the same, but we know that the opioids and endogenous opioids have a lot to do with mood. Without a doubt, a lot of how we are day to day is our endogenous opioids and how they attach to different parts of our opioid system. And again, can we develop these medications that would selectively kind of attach to certain ones and just get the good parts of the opioid and not the bad parts of the opioid? Boy, we hope so. There's been all this work done on trying to find something that's a mu receptor agonist that doesn't cause addiction, it doesn't cause dependence or tolerance. And that's kind of the thing that everybody's looking for. But can we also find something that is an antagonist at the kappa receptor that only gives us the mental health benefits, but is not addictive, right? So there's just lots of different ways to look at this. And currently, there's just a couple medications that affect these receptors kind of atypically, like buprenorphine, and attach in a way to the delta and kappa that might be of use to us. And there's actually a drug that is under investigation that is somewhat related to buprenorphine that is much more heavily a kappa antagonist. And that's been in studies here for a while, trying to find out, is this a medicine that we could just specifically use for mental health? Next slide. Now, again, historically, the poppy seeds and opium, these were used for lots of medical reasons. Again, for mood disorders. And I'm not talking mood disorders hundreds of years ago. Even into the 1900s and up until 1950, patients were still getting opioids for anxiety and depression and all kinds of things, literally because there was nothing else. And I got to be honest, I think 10 years ago when we did chart review, when I was at a different hospital system, I came across a lady who was on codeine for anxiety, and she'd been on it for 20 years. So, I mean, there were still physicians that knew that it would calm it down. And it was really a struggle for her to get off of that because she felt it was such a good anxiety medicine. Um, but in the 1950s, of course, they discovered the MAO inhibitors and imipramine and the tricyclics kind of came out. And of course, they had a lot of side effects, but they seemed to, what they didn't have was an addiction issue. And so those began to be used much more commonly. Next slide. So shortly after they found these brain neurons like produced endogenous opioids, they were working on all this stuff, and it was probably, oh gosh, it had to be mid 80s when Prozac came out. I can't remember, but the SSRIs have really taken over as kind of a first line for depression and anxiety and all these things. But the fact remains that only about 50% of people respond to these medications. And so there's really this push to find, other things that can either augment what you're giving a patient, or they can be taken off medications and started on something else. So this work actually began in the 80s to kind of investigate some of these different substances. And one of those, again, was buprenorphine. And the initial studies that were actually done were using beta endorphins to prove that they could inject IV beta endorphins, which were basically similar to what you had endogenously, and they would actually improve your mood, right? So how can we take this a step further? Next slide. So buprenorphine really became a focus in 1982, and as you can see, the mullet was still king. I think I knew a lot of people in the early 80s, and you know who you are, who had a mullet at that point in time. That is not a picture of me. And so really, that was the first open trial in 1982. And interestingly, the guy who did this trial is still doing stuff on this particular topic. Next slide. So what I did is I took these review articles and I kind of went through them, and we're going to talk a little bit first, just kind of running through what the kind of the definitions on these things are before we hit these studies that were done. And it's just important to understand that the partial agonist, it just has less capacity to activate a receptor, okay? You may not get as many of these multiple signaling pathways to go. With a full agonist, you might get all kinds of different pathways kind of activated, but with a partial agonist, in general, it's going to be less, but they can still be very effective, and they can still be a good analgesic. They can give you other different types of effects. Yeah. Yeah, The Mullet by Dave Rossmiller. And again, buprenorphine is a very high affinity, so it sticks on these receptors pretty well. And the good thing about buprenorphine is it also has a slow dissociation from the receptor. So it clearly hangs around and has effect on these things for a while. Now, remember, if you're a kappa antagonist, you're going to block the dysphoria, you're going to block that stress response, and you're going to have a positive effect on the affect, okay? And again, the delta antagonist, and although delta is not quite as well worked out as it comes to buprenorphine, but the whole thought is that it may help you kind of avoid that development of tolerance and dependence, especially if you're taking something for a long period of time. Next slide. So here's the things that have been involved in the research. Can we take this unusual receptor profile, and can we use it to our advantage? That's the million-dollar question. And here's the things that they have really dug into over the last 30 or 40 years. Suicidal ideation, self-harm, people that cut, people that self-tattoo, all these different forms of non-suicidal self-injury, major depressive disorders on their own, and they've looked into major depression also with OUD concurrently. And there've been, again, a small number of studies done on each of these to try and see what effect buprenorphine has. Next slide. So there's the warning. Everything I'm discussing is completely off-label and investigational. I am not suggesting that everybody starts saying, "Oh, you got depression? We're going to give you buprenorphine." I'm not going to do that. But I think that is there going to be a time where that might be the case, where in certain specific cases of very, very difficult poorly treated depression is an option as an adjunct. And that's the way they're looking at it in a lot of ways. But when we look at the patients that we're seeing for opioid use disorder who also have major depression, we're going to treat their opioid use disorder anyway. And are we going to see benefits in their depression and anxiety and all these other things? And is that okay? Well, obviously, yeah, that's okay. But there's a lot of kind of off-label reasons we've used bupe. And for the most part, the question is this going to be something that we do next? Next slide. So one of the biggest reviews that was just done in the last couple of years. And this was actually, it's a great name, Namchuk, was done in 2022. And this was a very comprehensive review of the papers that were kind of relevant to the assessment of buprenorphine as a treatment just for major depression alone, and also in opioid use disorder with co-occurring major depression. And now, to be clear, this review also has another section, which we'll talk about, where they compared buprenorphine and methadone in the treatment of comorbid opioid use disorder and major depression. And the reason that's kind of an important thing is because methadone being a full agonist, it has a different profile on the kappa and the delta receptors. So the question you have to ask yourself, is it going to be as good at helping people with their depression if they have co-occurring depression as buprenorphine? And we'll show you that stuff. I'm pretty distracted because Dave is wearing a Green Bay Packers shirt, which I hope everybody will send him some private messages about. It's pretty disturbing. All right, next slide, please. Yeah, that threw me off my game. Next slide. There we go. So here's the summary. Honestly, this could be a 4-hour talk if I'd went through every little thing that they did. And so I'm really trying to kind of pull this stuff into just a very concise kind of review. There have been 3 open trials, meaning people knew they were on buprenorphine. They were done by Emmerich, Nias, and Karp. Emmerich and Karp are still going. These guys are still doing this research. Emmerich started in 1982. He's still doing it. All of these looked at low dose effects on depression, especially in opioid naive patients. So again, no opioid use disorder, patients just coming in, they have major depression. They're giving them buprenorphine as just the only drug that they're on, treating them from anywhere around 1 to 8 weeks. The other 3 trials that they reviewed were random controlled trials. So there were people that actually did not know what they were getting, and our same people, Karp and Emmerich and now a new guy, Fava et al. They were all doing this really in the last 10 years. And I do think that Karp, it was basically a follow-up. His study was a follow-up to his first one that was open trial. Then he went to a random control trial. So these studies all looked at treatment-resistant depression. So these are people in this group, in the second group of random trials here. These were people who were given buprenorphine as an adjunct. So they were already on medications, but they were not responding. And so they were at that point given buprenorphine. And the doses, again, on these were, although slightly higher, in some cases really weren't that high. If we look at the doses that we're giving fentanyl patients, this is nowhere near that. So some of these people were starting at 0.5 milligrams a day for their whole treatment course. Others were on 8 milligrams a day. And the treatment lengths in these 3 studies went anywhere from 1 week to 12 weeks. All right, next slide. And so here's where it's kind of gets interesting. if you compare how buprenorphine acts as compared to, I got this fly who's driving me crazy here. If you compared buprenorphine to just traditional antidepressants, let's face it, we give people medication. We don't say come back in 10 days. We don't say come back in 3 weeks. If we say come back in a month, and maybe at a month, we're going to see some kind of response. In 4 of the studies that were done that they reviewed, they demonstrated antidepressant efficacy in patients with treatment resistant. Again, these are the tough ones in just a week. And that these patients actually had lower Hamilton rating scale for depression in only a week's time. And in many cases, it was 48 hours or less that these patients would get this. And this will, I think, be more interesting too, as we talk about the suicide, patients with suicidal ideation and how quickly that can act. And really their conclusion was that although the number of studies available is really small, there's just clear indication that even just low dose buprenorphine can really rapidly and significantly relieve some depressive symptoms in patients that are opioid naive. And so, it's out there. And there's a little question that popped up. Do you think that insurance companies will cover the cost of this? And it went away. But again, off label, not something I'm probably going to start doing yet, but interesting as we look at treating our patients who have an opioid use disorder and some of the other off-label reasons we would use buprenorphine. For instance, chronic pain, because chronic pain and major depression, there's clearly also a big overlap. Okay, next slide. So the summary of review of this is people with major depressive disorder who also have an opioid use disorder. I think we all see this all the time. So these patients had a previous diagnosis of major depression and show up and they have an opioid use disorder. And this clearly happens much more often, higher incidence of major depression in people with opioid use disorder than in the general population. And in fact, major depression really in this group ranges anywhere roughly around 50%, if you're just going to pick a number. But depressed opioid use disorder patients are also patients that are difficult to retain. They're more likely to drop out of treatment than non-depressed patients. And so how can we, what are we doing that's going to keep them in treatment? Next slide. So this is the summary of the different studies that they looked at. And the first one was the prescription opioid addiction treatment study, which they called POTS, showed a couple really interesting things. That first off, if you had a lifetime diagnosis of major depression, that was the best predictor of a good outcome with buprenorphine for treatment of your opioid use disorder. So if you come in and you've got this long history of depression, they put you on buprenorphine. In fact, your depression is a little better, but you're much more likely to be retained for your opioid use disorder. And it's not, and as you can see that, it's not like you're not going to give somebody with an opioid use disorder buprenorphine. I mean, that's one of the difficulties with doing these trials is I can't say, okay, I'm going to have another group where we don't put them on buprenorphine and see how they do with an opioid use disorder. But the outcomes appear to be best, obviously if both are treated. When we see patients who have both of these problems, you definitely want them to be, both of these things to be treated. And is buprenorphine the medication that does that? I think a lot of you, like myself, have seen patients who were pretty depressed, pretty down. You start them on opioids, you start them on buprenorphine, they come back a couple weeks later and they feel markedly better. And is it because we also treated some of their depressive symptoms as well? And I think that's something we have to consider. Next slide. So there have been 2 open trials with this particular situation with depression and OUD, and they were by Costin and Romero Gonzalez et al. One was way back in 1990, but the other one was very recent, just 6, 7 years ago. And these dose ranges were a little higher, so they were using 2 to 8 milligrams of buprenorphine, and it varied a little bit. But the other study was actually using 16 milligrams as a fixed dose. None of these patients were on any other medications. So these are people with major depression, but only on buprenorphine. Next slide. So There were three random controlled trials reviewed, Dean, Dreyfus, and Amati. Now, I'll tell you that the Amati study in 2018, which was pretty recent, I believe was done in Iran. And in Iran, they do not continue people. Well, am I getting a little background noise? I got people wandering by. Can you hear me okay, Aaron? Okay, good. Um, Amati is, I believe, in Iran, and they're, in general, from what I could get from his paper, is that they give people doses of Suboxone for opioid use disorder, but they do not continue them at this time. So in all three of these studies, the ranges in dosings were huge, right? In one study, it was anywhere from 2 milligrams to 32, the other 8 to 32. And the last study done by Amati were single doses that ranged anywhere from 32 milligrams to 96 milligrams, one-time dose in a single day. So the first studies evaluated patients over weeks to months. The last looked at the response at 3 days and 2 weeks. And again, so the first one actually a fairly long study, but in the study done by Amati, it was they were seeing them back in a week or two. You know, how's your depression now? You know, they treat their opioid use disorder with just for a day or two, and it's like, what did this big dose do for your depression? Next slide. So really, when they summarized what they found in these studies actually supported the use of bup to treat comorbid opioid use disorder and major depression, but clearly there needs to be more research. Some of the future studies, you know, wouldn't it be nice if there was placebo-controlled studies, but when you have a patient who has opioid use disorder, pretty tough to pick a group that's not going to get buprenorphine. So I think that's going to be really difficult. Higher doses did not improve major depression outcomes. So much like we think about for other things, like respiratory depression and other problems with buprenorphine, there appears to be a ceiling effect for depression. Like you take a certain amount, your depression will be a little bit better, you'll be better. But if you go higher, it's not even more improved, right? So there does seem to be some dose, some soft spot when we look at the effect on that kappa receptor. And again, these studies confirmed what had been found before, is that the action is really pretty rapid of treating that major depression in comparison to conventional antidepressants. Next slide. So the study on bup and methadone, you know, does this give us some clues too? Because again, methadone is a full agonist. It's totally different kind of drug than buprenorphine. And there's actually been three studies, one of them a randomly controlled trial. But two of these were just observational studies and but they showed as well this greater antidepressant activity for buprenorphine. The randomly controlled trial actually was a wash. It didn't really show one being better than the other. And so, you know, this is an area where there's just going to have to be more work done. Next slide. So this is some of my favorite stuff right here. Bup and the acute suicidal ideation. Suicide's a big thing, right? I mean, if we look at suicide on its own, there's as many deaths from suicide in our country as there are from opioid overdoses. And so, and especially when we think about how many of these opioid overdoses were actually suicide, we don't know. But the numbers are just creepily pretty similar between the two problems. Next slide. So there's a lot of case reports, and if you Google this, you're going to find all kinds of case reports where people had suicidal patients who got buprenorphine, and the next day their symptoms have been resolved that have been there for days and days. There's actually two randomly controlled trials. One was a very low dose one. The other one was a single macro dose, and again, I believe that was Amati doing that. But the first study used an average of 0.44 milligrams a day. We're talking a fourth of a 2 milligram strip. We're talking tiny doses. The second one used these single doses again, these 32, 64, and 96 milligrams one-time doses for people with suicidal ideation. And really, for both of these studies, they used the Beck scale for suicidal ideation. And the follow-up for the first study was 4 weeks, and the second one was 2 weeks. And so we'll change the slide here and show you what happened. And really retrospective evaluation of this showed that a subgroup of patients with personality disorders, especially the antisocial and the borderline patients, this does not work on. So there is a subgroup of patients that, for whatever reason, do not respond to buprenorphine when they have suicidal ideation. If you push those particular patients aside, the preliminary study showed effectiveness in treating both suicidal ideation in opioid naive and opioid use disorder patients. But again, when we look at that group of patients who have personality disorders, for whatever reason, you're just not going to get this response. Next slide. Lastly, I think, let's talk a little bit about non-suicidal self-injury. So patients that may cut themselves, injure themselves, self-tattooing, all kinds of things. Prevalence of this in the population is actually about 4%. But this behavior actually doubles all-cause mortality. So any patient that you see, and I have quite a few patients who have cuts all over their arms, their mortality is high and their risk of death from suicides, what are thought to be accidents and overdose, are extremely high. Now, the endogenous opioids somehow play into this whole self-injury thing. And often if you talk to a patient who is cutting themselves, they will tell you how good it feels, how pleasurable it feels. And it might sound strange to you. It's kind of like that old running dictum where, you know, I love running, and especially because when I stop, it quits hurting. It's this whole weird thing about pain that runners maybe enjoy the pain, and the cutters clearly they get a positive response from the injury. And we know that if we give those patients, some of these patients respond well to naltrexone and naloxone because it blunts that. They don't get the dopamine response that they normally would with the self-injury. Next slide. So these studies are extremely rare, but the one study that's cited by Norelli actually had a case series of 6 patients that had been tried on everything to improve their self-injury. And they were all given bupe at varying doses. These 6 people were on bupe for different dosing people. And I don't think it was the same provider that was actually treating them, but they were following these patients. These buprenorphine was added just to augment what they were already on. Most of these patients were on antipsychotics, benzos, seizure meds, naltrexone, all kinds of stuff. All 6 of these patients showed improvements in their behavior. Now, how they quantified that, I don't know. These are just a case series, but it's kind of a hint that the buprenorphine can make a difference in this particular situation. Next slide. So obviously more research is needed. Random controlled trials are needed. Again, the current case reports are really the most compelling part of this particular subject. And the authors of these things basically said, listen, off-label use for this should only be considered when you've tried everything else, despite the fact that buprenorphine is, as we know, very safe. But it's, again, not something that's been studied heavily. There's really no recommendations as far as dosing. And again, all those patients were dosed at different levels. And so this is something that's really in process. And I think over time, we're going to get more and more information really on all of these different topics. Next slide. So in summary, again, bupe may have some benefits for treatment of major depression, both in patients with opioid use disorder and opioid naive patients. There is a fair amount of evidence coming about that suicidal ideation responds to it very quickly. And obviously in an ED setting or in a clinic setting where you're worried about somebody, this in the future may be an option. But we do know that these opioid receptors probably play a large role in people's mental health. And there's just going to need to be a lot more research so that we can, again, find novel drugs which may selectively activate particular receptors to give us the responses that might help our patients more in these particular situations. So that is all I have. There are a million references, and These things are very interesting. Honestly, it was one of the most fascinating things I've read about bupe in quite some time. I don't know if there were questions, Aaron. I wasn't watching the chat all that well.
I have one for you.
Yeah.
You talk about in the articles where a lot of other mental health medications have been tried without success. Did any of these articles bring up like that gene site testing was tried or looked at? And would that be effective to see if bupe is a stronger alternative than others that were trialed?
No gene site testing mentioned at all. Again, it's interesting too that the Minnesota State position on gene site testing is that it's based on bad science, and so they don't pay for it. I don't know how people on here feel about that. I see Dr. McClure. I don't know how you feel about the gene site testing because it was around when you were practicing.
I don't think it's quite ready for prime time yet.
Yeah, but it gets ordered a lot, but insurance often won't pay for it.
No.
Yeah. Yeah, so there's not much mentioned about that.
Interesting. I saw earlier on Alex did ask, wonder if there's any lit on patients being poor metabolizers who experience higher bupe doses or are more prone to intolerances.
Yeah, and there is not. Let me tell you, there is a paucity of information on these things. It's really pretty interesting. Other questions in there?
John asked, were any of the patients treated with bupe assessed at a 6 and 12 month for remission?
Absolutely nobody. The farthest anything went out was, I believe, 12 weeks. And so, what do we learn? Do they relapse? Do they, we don't know that.
So anecdotally, I have an N of 4 or 5 and have people on bupe for decades and stay in remission. And it can be tiny doses. Kurt, you probably took over one, and I think she's on an 1/8 of a milligram a day and has been for a couple of years, or had been for about 5 years when I retired. And every time we go a little bit lower, the anxiety would come back, the suicidality would come back, and it would be in remission at a 1/2 milligram a day or less.
Yeah, that is so interesting. And it is really interesting when you look at it, because the doses a lot of these studies were done at, I think we'd all look at that and go, how could that possibly do anything? But yeah, that little of a dose and you get some response.
I'd get a call from the pharmacist every year. Really? 1 strip a week? Yep.
Yeah.
That's all it takes.
Wow.
That is interesting. All right. Do you think insurance companies will cover the cost of buprenorphine treatment? No, I don't know about the future. I mean, I think down the road, when there's more evidence, it's probably something that has to be prior auth. Let's face it. I mean, if you were going to do this, if I was ever going to do this at any point and there was better data, I would be using Subutex that's cheap, off-label, and you could do it for $50 a month, and people could probably pay for that using GoodRx. But I'm not quite there yet. I'm certainly not quite there yet. But if I had an opioid use disorder patient and I was bringing them down and they started to have depression or anxiety, like Dr. McClure is saying, would I stop it? No, I'd leave them on that little dose if that's what works for them. And I would feel perfectly fine about that.
I want to know, how do they get the cats and dogs to hold the bupe under their tongue?
Yeah.
No, how do the vets dose it?
I don't know that. I think they use fairly small doses. I think they use like 2 milligrams or less. They use really tiny doses. I know that, but I kept running across as I'm searching on buprenorphine for animals, and it's like, yeah, but I didn't look real deeply into that.
Well,
They use syringes. My wife's a vet. We use buprenorphine all the time.
They use
For
syringes?
sub-Q?
Syringes, yep. No, they put it in their mouth. It's like 0.1 cc's, just like square in there.
How many milligrams do you think of?
Tiny doses. Tiny
Yeah.
doses.
I know they're little,
Mhm.
but I thought that they also give them, don't they also give them little pills they just shove in their mouth?
I've only seen the syringes.
Interesting. Huh. Yeah.
Do you
well,
know
that's the
I
hard-
heard something very interesting yesterday. So we've had veterinarians come on Echo and speak about how medications are regulated or lack thereof in veterinary medicine. And it was interesting, Costco actually allows you to fill your animals' prescriptions there. So they will enter controlled substances into the PDMP database and put a little animal logo next to it. I was like, holy moly, that's really neat that they're starting to look at that a little bit from the veterinary perspective.
Take your dog in for chronic pain to get your bupe.
Yeah.
Well, the metabolism in animals is so much different because we had a 14-pound dog who got really anxious in the car and they gave her trazodone. I'm like, what dose? And they said, 50 milligrams. I'm like, what?
Yeah, that seems like a lot.
Even that didn't snow her. So when I did the bupe training, they put up a slide that showed like over time, and I show it to patients. I just label it brain chemistry, and it starts off on the left side with this gradual thing, but going down. You put people on bupe, and you get a curve that levels them off.
Yep.
And I just say, we're going to take you off this roller coaster, and we know that you make more, testosterone and dopamine when you're on it than if you're on opioids.
Yeah. Yeah. There's something to that.
And by the way, I'm a Packer owner. I own one share.
Oh, that changes the whole outlook of that I have towards you now, Dave. Now there was somebody, Craig said he had same experience as Dr. McClure with quarter of a 2 milligram daily, has some patients with that same kind of issue, that's really interesting. Anybody else? Any thoughts or questions? Again, there's gonna be more to come every year. I think this is something, I'm gonna look at every year and just see what's new because it is interesting.
I don't know if Charlie's on, but man, they should have a protocol at Hennepin for suicidal patients and do a trial.
Yeah.
Too bad Claire isn't on here because she does hospital medicine, but I would think, and Charlie too, for someone who's actively suicidal, I suspect they're probably going to go more towards ketamine than they would with buprenorphine here in the States.
Yeah. Yeah. Yeah, we'll see. Maybe it'll change. And
I'm like you, Kurt. Unless they had an opioid use disorder, I'm not going to touch it.
not yet.
Not yet. No.
Yeah, we got to have a little bigger trial, and we got to have a little better idea of what we're going to dosing. But again, for the patients that we see, one of the things that's really unclear to me is that if I put somebody on opioid who has an opioid use disorder on a bigger dose, is it not as good as a smaller dose, right? I mean,
Right.
Are we having a negative effect potentially as we go up on the dose?
Yeah.
Or at least neutral. So I feel a lot better about giving buprenorphine to people that are kind of on the edge as far as opioid use disorder. If they also have depression, I'll probably be a little easier to convince. But I think on its own, with just depression, I'm not there yet.
The downside for me is even a robust response is 70%. Now I've got 30%, their depression's no better, and they're dependent on buprenorphine.
Yep. There you go.
Sadly,
And there's
probably
not
gonna,
an antidepressant around that gets 70%. So you're talking 30 to 50%.
Yep. Yeah, that's
sadly,
true.
it's probably going to boil down to money for if it's ketamine or bupe. Who's going to make more money?
With
Yeah.
ketamine, is there any sort of dosing cadence or recommendations? Or is it sort of like the buprenorphine where it's not a one size fits all and everybody's different?
It's not a one size fits all, but it's a fairly narrow window. You're talking 0.5 to 0.75 milligrams per kilogram for the initial dose, maybe up to a milligram per kilogram for a second dose. That's IM or IV. And then I've seen patients walk out of the office, my suicidality's gone. And then come back next week, it's still gone. So
What's the difference, Matt, between, you know, like you're saying, walk out of the office? If I get somebody in the emergency department and they're having a lot of suicidal ideation, if you give them ketamine, how long do you have to wait before you discharge them?
the dissociation can last up to 90 minutes. So another half hour after that. So I'm holding them for 2 or 3 hours
Okay.
and then discharging them with a driver.
Yep.
I don't let them, they don't drive home, no.
That's
But
good.
it's, it's got a great safety profile. We're using doses that's a quarter to an eighth of what you're going to use for a general anesthetic.
Mhm.
So,
Interesting. Yeah, we may have to have you give a ketamine talk.
That'd be interesting.
It would. I don't know.
well, I've only got an N of about 15 treatments, so I'm not very experienced yet.
All right. Well, when it gets down the road, chat with us.
When everybody asks me, how many have you done? Oh, not quite 100 yet.
Yeah, yeah.
It's kind of like, that was my response when I was delivering babies too. Not 100 yet. You're my
All right,
first,
anybody-
man.
Yeah, you're my person. Any other questions before we let everybody get back to work? I hope that was fun for everybody. It was really fun for me because I like this topic, but it's just so quirky. So,
I had to go get some Mohs surgery done on my scalp. And I walked in and I walked out of the elevator and almost walked into the medical office that was doing ketamine. I'm like, oh, that's not the right.
why not?
Yeah, I'll take some of that for my Mohs procedure, please.
All right, everybody. Well, everybody have a good week. We're back in a couple weeks. I think, is it Cole Peringer then?
Mhm.
Yeah. So Cole, of course, a great speaker. And we'll see you in a couple of weeks.